My name is Hardefeldt. I'm one of the PhD candidates in the animal stream, and my background is I graduated from veterinary school in Western Australia in 2003, and I worked as a predominantly equine vet in general practice and then as a specialist in internal medicine for the last 6 years, and have been now doing my PhD for the last 11 months. And I'm looking at antibiotic stewardship. So somebody asked at lunch what the definition of antibiotic stewardship is, and I think it's one of those things that is interpreted widely, but when I'm talking to vets about antibiotic stewardship, I say that it's choosing the correct antibiotic, using it for the appropriate duration, giving it at an appropriate time and dose, but I think importantly it's withholding antibiotics when they're not indicated, and I think this has been a good shift from the term judicious use, so because it does incorporate not using antibiotics. And the clinical standards for human medicine are, I think, not too much different for veterinary clinicians as well. I think they can be translated across in a lot of circumstances, and we don't have clinical care standards for veterinary clinicians, but we can certainly do a few of these things pretty easily. Taking samples for culture that certainly can have some challenges with cost constraints, and we do have limited guidelines available for veterinary practice. There are some small animal guidelines available, but none for equine or bovine practice. So that's something that presents some challenges, but certainly we can do the rest of these things. We can educate and involve the owners and farmers. We can document prescriptions, reasons and review date, and actually we're pretty good at doing this already. We can review treatment and seek advice when necessary, and this might be an area where NCAS might have a role in the future, and we can switch treatment when indicated. But if we look at the overall aims of antimicrobial stewardship in medical practice versus veterinary practice, in medical practice it's really been around improving compliance with these guidelines, reducing antibiotic use, reducing resistance both at a local hospital level and at a national level, and improving patient outcomes at a local level and at a national level. Whereas for veterinary AMS, really the aims have been around restricting antimicrobial use and limiting antibiotics in food, residues in food-producing animals. And this has been based on regulations, and all other facets of antimicrobial stewardship are really minimally developed. And if we want to move to a medical system, we need some of these. We need to be able to do some of these basic things. So we need to be able to measure antibiotic use, which we can't at the moment. We don't have ongoing surveillance of antimicrobial resistance, and we don't really measure patient outcomes even at a hospital level or a clinic level. And as Lord Kelvin famously said, if you can't measure it, then you can't improve it. And so my PhD is really evolved around developing some of these tools. So we wanted to look at self-reported antimicrobial usage and compliance with the existing guidelines where appropriate. We wanted to develop a means of measuring antibiotic prescribing, and so we've been working on the vet maps. And most excitingly for me is the third aim, which is to develop and evaluate an antimicrobial stewardship practice for veterinary practice, so that we have some evidence-based stewardship options for vets to implement. So I'm going to share some data with you, mostly from the first part of my PhD. So the Australian Infectious Disease Advisory Panel is a group that developed some guidelines for small animal practice around 2013, and preceding that in 2011 they ran a survey looking at antibiotic prescribing for the exact conditions that they ended up developing the guidelines for. and they had a very good response rate. There was about 900 people responded to the survey, which was more than 12% of the population of vets at the time, but they were predominantly companion animal practitioners. So, and they looked at 11 medical, 2 surgical and 8 dermatological conditions. So the overall antibiotic use throughout the survey, unsurprisingly to us, the beta-lactams were the most frequent class of antibiotics, but somewhat concerningly, the 3rd generation cephalosporins were, along with the tetracyclines, were equally the most commonly used in cats. And in 2010, there was a long-acting 3rd generation cephalosporin released for veterinary practice in Australia, and it's marketed as Convenia. Cats are notoriously difficult to medicate, and so for convenience, it's very frequently used. But concerningly, it was used in scenarios where other, lower importance rating antimicrobials are likely to be as, if not more, effective. And then also, concerningly in dogs, the second most frequent was fluoroquinolones and the 1st and 2nd generation cephalosporins. And the fluoroquinolones were interesting because this peak was mostly due to use in otitis cases, in ear infections, where systemic antibiotics are usually not recommended, and certainly not recommended in the guidelines. Other high importance rating antimicrobials were really used very minimally in the survey. So then we looked at agreement with the guidelines. We couldn't look at compliance because the guidelines came out after the survey, but we were interested in agreement, and moving forward we're interested in looking at compliance with guidelines. And there was really 4 conditions where compliance was particularly poor. And that was for different reasons. So if we look at the top slides, for gingivitis, the empirical culture and sensitivity choice of was pretty good, but the selection of drugs, particularly for cats, was poor, and the duration of therapy was generally too long, whereas for cystitis, the guidelines recommend culturing these cases on the first visit, and that was generally not done, which led to the poor compliance or poor agreement in that group. Whereas for the more severe conditions, pyonthorax and peritonitis, there was actually an underusage of antibiotics, so the guidelines recommend triple antibiotic therapy, and that was not done in the majority of cases. So then we were interested to see what was going on currently. That survey was 5 years ago, and so this year we ran a survey looking at antimicrobials for surgical prophylaxis. It's the first survey of surgical prophylaxis in veterinary medicine, and we wanted to look beyond small animal practice. So we also surveyed equine practitioners and bovine practitioners, and we had a similar response rate, around 900 respondents, and a good mix of the 3 classes of veterinarians. So again, the most frequently used antibiotics were beta-lactams, closely followed by 1st and 2nd generation cephalosporins in the companion animals, and we were pleased that there was actually very low usage of any of the antimicrobials with high importance rating. And we did look at compliance both with the ADAP guidelines and with the British Small Animal Veterinary Association guidelines. And in this study we were able to also look at suboptimal antimicrobial usage. So we defined suboptimal use as choosing the correct drug but not having the duration or the dose or the timing correct. And for most of the conditions where antibiotics were not recommended, for both the neutering and these 2, our compliance was moderate, and of course where antibiotics are not recommended, there is no suboptimal. Whereas for the orthopaedic conditions and the exploratory laparotomy, we had most people choosing the right drug, which was encouraging, but they were either getting the timing wrong, but more commonly it was the duration. So the guidelines recommend stopping within 24 hours, and most people are treating beyond that period of time. We also looked at a multivariable model here to see if there was some specific groups of practitioners that we could target some education at. And the companion animal practitioners were doing a better job than mixed practitioners, so the odds of compliance were higher in that group. And practices employing more than 2 vets also had better compliance. So this is probably around access to continuing education in companion animal medicine and surgery. We thought it was interesting the vets from the ACT also had higher compliance than those from all other states, and the ACT has recently implemented a antimicrobial stewardship trial, and it's quite a small state, and quite a significant proportion of the vets from that state are participating in the trial. So this might already be some early indications that that's improving compliance. We were also interested that recent graduates were less compliant than older graduates, and you would have thought that might have gone the other way around. But we think that there's quite a bit of peer pressure coming from other practitioners in the clinic, and that our recent grads don't have a lot of confidence in their decision making, and this might be leading to the lower compliance. So I also have some data from the equine part of the survey, and to me this was not a huge surprise either, that the most commonly used were beta-lactams. We did have some long-acting beta-lactam use in horses, which is interesting because the long-acting beta-lactams don't hold very well in terms of serum levels in horses. And then trimethoprim sulfonamides and gentamicin were also in the top 3. We looked at compliance with the British Equine Vet Association guidelines, and again we looked at optimal and suboptimal with our same definition for suboptimal compliance, and we can see that most people are choosing the right drug, and along with the duration being too long, the other common issue with the equine prescribing was that the dose of beta-lactams was inappropriately low. And this really highlighted one of the big issues I think we were going to have in the veterinary side, in that the labelling of our large animal antimicrobials is often the dose on the label is different from the recommended dose, and that's certainly the case with procaine penicillin, where the dose is substantially lower than that that's commonly used in medicine and recommended in the guidelines. Again, we did some multivariable modelling. Recent grads had a trend towards being less compliant, consistent with the small animal data. There was only about 200 vets who completed the equine section, whereas there was 700 in the companion animal section, so that might have resulted in a slightly higher p-value. And university vets were more compliant, which was encouraging. The bovine section, just quickly, the oxytetracycline and the beta-lactams were the most frequently used in this group as well, and there's no guidelines in the English-speaking world about antibiotics for bovine practice, so we couldn't look at compliance in this section. But again, the doses with oxytetracycline and procaine penicillin were very varied between practitioners, and the dose that's generally recommended is different from that that's on the label as well. So our future work, we have a pilot trial that's ongoing of the veterinary NAPs, and we're also awaiting some ethics approval for a qualitative study to look at the enablers and barriers to antimicrobial stewardship in veterinary practice, and following that qualitative study we hope to roll out some antibiotic stewardship initiatives, and we've got quite a few practices that have already indicated their willingness to participate in that trial, so I'm very excited about that. Be happy to answer any questions.
spoke about one of the issues that it's about having guidance to know what to prescribe and information on labels. And I'm just wondering how, you know, where do veterinarians on day-to-day level get their education from? And in particular, how much of a role do the pharmaceutical industry play in that?
Yep. So that was one of the questions we asked on the surgery survey, was where people get their information about antimicrobial prescribing, and our pinwheel came up as a rainbow of colours, so there was no one clear source. If we looked at our recent grads, about a quarter of them said that their university notes were the most important place, whereas when we looked at the older grads, it was really a mix of everything. So I think we had about 13 different sources on the list, and they all represented an equal part of the pie, which says to me that there's no one good source of antimicrobial information, and that's something that veterinarians are crying out for, is somewhere that they can reliably find information about prescribing, and a lot of that comes back to the fact that there's not a lot of big research trials done on therapies, and so it's hard to have therapeutic guidelines that are based purely on evidence. But I think we need to develop some guidelines, and certainly that's been one of the initiatives of the Australian Veterinary Association is to do that, but it hasn't progressed very far as yet. So. Karin.
Up the top.
Laura, just checking, just to make sure you acknowledge who funded the ADAP survey.
Yes, the ADAP survey was funded by Zoetis, which is one of the pharmaceutical companies, as were the guidelines.
Okay. Thanks, Laura. That's fantastic. Trump 129, Clinton 79.
Hello, I'm Helen Billman-Jacobe. I'm from the Faculty of Veterinary and Agricultural Sciences, and I'm not a PhD student, but I want to touch on a couple of projects that some of our PhD students have been looking at. So I'm interested in the occurrence of antibiotic resistance genes in livestock, and within NCAS, we're only just getting started on the livestock stream. We've recruited a PhD student who's really yet to get into her project, and we're looking for a new postdoc. So anybody who's interested, we'd be very interested to hear from you. So what I want to do is talk a little bit about a project of a student who's about to finish, and how that's informed our thinking on the project we're planning for the current PhD student. So livestock production systems are complex, and the microbial communities associated with the livestock are under a whole variety of selective pressures. And the selective pressures from the use of antibiotics have been, those antibiotics in food animals, have been implicated in the selection and maintenance of drug-resistant bacteria. Now, there are also a lot of non-antibiotic compounds with antimicrobial activities that are used in animal husbandry and animal management, and the impact of those compounds on microbial communities is less well understood, and we'd like to cover that in some of our. I just realised I'm not on my slide, which is okay. I'm just about to. Here we go. Okay, so what we want to do is to essentially look at microbial communities and the carriages of antimicrobial resistance genes in those communities. Now, I want to tell you a little bit about a project that was done by Tom Weaver. This was in collaboration with MDU, the South Australian Research and Development Institute, and was supported by Australian Pork Limited. So what Tom was doing was looking at a particular serotype of Salmonella in Australian pigs. And so this is a very targeted looking at a particular subgroup of a microbial community. He was interested in this particular variant of Salmonella typhimurium because in passive surveillance in animal isolations, we started to see the occurrence of this increasing in Australian isolates. In a global context, this variant, which has got a pleasant sort of name, but we call it the monophasic variant of Salmonella typhimurium. Why it's of interest is if it's starting to occur in livestock in Australia, is it likely to follow trends that we've seen overseas? So overseas there's two main clones of the monophasic Salmonella typhimurium, and one of those clones is very, has been implicated with multiple drug resistance. So there's two clones. The European clone is tetra-resistant to ampicillin, streptomycin, sulfathiazole and tetracycline, and the other one has a much broader, up to 8 or more antibiotic resistances. Now in Australia, pigs have got a low prevalence of Salmonella typhimurium, and so we're looking at this low background and the possible introduction of a new variant or the evolution of a new variant from the existing pool of bacteria. Now the antimicrobial aspects of this was just a small part of Tom's study. So what he did is he went out to 18 pig farms and extensively sampled fecal material and isolated many hundreds of salmonellas, and I'll show you some of the results just for the serovar, the monophasics. This panel shows on the right-hand columns the number of herds and the number of isolates that match a particular antimicrobial resistance profile that was determined. So what we see is that predominantly the most common type that he saw matched the tetra-resistant European clone profile. And so this was the dominant. In the 11 farms where he found the monophasics, 7 had this as the dominant organism. But the next most common ones were ones which had a diminished range of antimicrobial resistance. And then we've got all these varieties here which essentially represented the acquisition of some extra resistant markers, mostly on mobile elements, mobile genetic elements. We saw very few sensitive strains of this particular serovar, although in the same herds we saw other serovars that were fully sensitive, and this will come back to what I was saying, how a project looking at a specific organism can give you a skewed perspective on what's happening in a microbial community. If we map, we took a whole lot of these and sequenced them, and like Ben showed before, we could take whole genome sequencing and work out the relationships of the various organisms, and what we generally saw is organisms isolated from a particular farm were really closely related. The organisms between farms were also fairly closely related, suggesting a common source of introduction in the recent history in this industry. When we dig down and look at the resistance genes or the resistomes of these organisms, what you see here represented in the blue bars are the occurrence of a number of genes, and these absolutely matched the laboratory data for the antibiograms, and we see some different sort of barcodes, if you like. Organisms here had the tetra-resistance. This particular farm had a wider range of resistance, again mobile elements coming into the genomes, and some have got narrower spectrums. What's uniform within the groups is this bar coming down here, is that nearly all of them had at least one marker for tetracycline resistance. That is not surprising when you look at the imports of drugs, antibiotics for use in livestock, and put them against the industry where they're used. tetracyclines, which this graph shows are predominantly used in pigs. The way it's administered to pigs commonly is as a prophylactic, as low-level concentrations in feed, and this is for the prevention of disease, the prevention of specific diseases like ileitis, for which alternatives aren't readily available. We were interested to see whether possibly selection with one or few antibiotics were co-selecting some of the other markers. So if we looked at the gene arrangements, what we saw is in our whole collection some common trends. If this represents part of the genome, the Salmonella typhimurium, every one of our hundreds of isolates had a specific deletion between these two genes, and that was replaced with a whole lot of more genes. Now the deletion results in its monophasic phenotype. The acquisition of this slab of other genes includes the genes for ampicillin, streptomycin, sulfothiazole and tetracycline resistance. So this is being carried very stably on the chromosome in many of the isolates. And the ones that had a narrower spectrum of resistance have got specific deletions in this locus. And there's a whole lot of bias elements in there where you get chunks of the genome just looping out. So they've got a common history, and their carriage of genes reflects their phylogeny and not necessarily the current selective pressures that these are under. So we're seeing degradation of this locus. At a much higher level, one of our isolates had this genomic island. The genomic island has a set of genes that encode arsenical resistance. Arsenates have been used as in-feed therapies in livestock in Australia until recent times, and they've been predominantly used for control of coccidia. This practice is no longer current, and so we may be seeing the maintenance of this as it's slowly dying out in populations. But we see a whole lot of copper, zinc and cadmium resistance genes. Copper and zinc are essential elements. Copper can be added into diets at higher levels above what's needed as a trace element through growth promotion effects. And so we're starting to wonder whether some of the other animal husbandry practices are driving the population structures. The other loci that we could see where we detected antibiotic resistance genes showed that they're mostly on mobile elements. Sometimes you get co-selection of a whole group of genes, and sometimes those genes were in combination with some of the metal resistance loci. The new PhD student at Yuhong Yu, who's come in to the NCAS project, has started to look at these types of gene arrangements. What her goals will be is to step away from looking at this very specific small subset of a microbial community and to look at a broader microbial community, looking at chickens, pigs and hopefully cattle as well. So the goal with Yuhong is to essentially look at the microbial microbiomes and the subset of genes within those communities that represent the antimicrobial resistance genes, and try to relate those to the selective pressures that are current within the production systems. So rather than look at specific pathogens, we want to look at communities, and rather than look at whole genomes, as Tom did, we want to look at selected genes. And so we're going to select the antimicrobial resistance genes, the heavy metal resistance genes, and some of the genes associated with mobile elements. How we're going to do this is using quantitative high throughput PCR arrays, where we'll be able to take a fecal sample or an environmental sample within a farm and screen that for 200 genes simultaneously and end up with a network analysis of the abundance of genes within environments. So the sort of data that we anticipate generating will look something like this, and this is from a recent paper looking at some pig farms. So the bottom panel represents the rhizostome in a US pig farm. Each of the dots represent a particular gene or group of genes that have been assessed in the high throughput arrays, and the lines that connect the dots are the statistical co-occurrence indication. So when you get a cluster of connected genes, these are co-inherited. The more complicated profile at the top is from a Chinese pig farm, where there is a lot more markers that are present in the most abundant genes within those communities, and there's more complicated interactions. You can also look at the genus level, or in some cases the species level, of the actual names of the organisms that are participating in these communities and infer carriage. So what we're going to be doing is initially looking at layer chickens. So a layer chicken would live for 80 weeks, and for the most part of its production life it's not fed antibiotics because they're in their laying, but it's quite a long time. A pig lives about 6 months, whereas a broiler chicken could live as little as 5 weeks. So we're looking over the lifetime of animals within production, and we're going to look at different production systems. So in the case of chickens, we'll look at free range and layer chickens, and in pigs we'll probably focus on the conventional indoor housed pigs rather than free range, partly for a sampling convenience. And what we're really trying to see is what is a baseline level. How can we measure what are the genes that are in these communities and the associations with those, and get a bit of a profile of what's currently circulating. And we have a fairly conventional approach to the use of antibiotics in livestock in Australia, and we're anticipating to see a profile more like this with a fewer number of abundant genes, but we'd like to track those throughout the production cycles and relate that to animal husbandry practices. Thank you. I hope to tell you more at the next annual forum.
Any questions?
Karin.
Very nice presentation. Has anyone with a salmonella cells with milk resistance genes, has anyone checked if those genes are being expressed and are actually resistant?
We're doing that right now, yes. There are a number of different genes. There's some additional ones which I didn't put up there. That question of phenotype versus genotype, I think, is prime. Going out and looking at the genes can lead you to leaping to conclusions about and speculating about selective pressures, whereas we really need the phenotypes. So with the salmonella group, they're going to be fully phenotyped, quite an extensive range of genes there, and that will partly influence some of our choices in the arrays. We've got 200 gene capacity within the arrays, and actually making sure that we are comprehensive, but also making sure we're not missing any that are relevant to these production systems.
Well, maybe I can just comment, because it raises the interesting question whether what we're trying to do when we ship farms off antibiotics is drive them onto other solutions without actually achieving.
Yes, well,
Canada has seen this happen where the best use or the least use of antibiotics actually result in more resistance because
so some of the things that I mentioned that you can add, if you add the amount of copper which is required for metabolism, about 10 times more copper is what gives it the growth advantage effect. There's a heavy use of organic acids in feed as well to manipulate growth and feed conversions, and we have no idea how that actually influences the microbial communities. So the best farms that I want to study are the ones that have low antibiotic use and are using these alternatives. and it doesn't have an effect on the actual circulating population of antimicrobial genes.
Thanks, Helen.
Okay, good afternoon everyone. My name is Jaclyn Baker and I'm the PhD candidate for the Regional, Rural and Remote stream. My background is as a pharmacist and I currently live and work in Ballarat, which is a regional city about an hour and a half from Melbourne, in medium traffic, heavy traffic, who knows. So certainly can relate to a number of the issues that will be raised throughout my presentation. So this is an overview of what I'll be covering in the presentation today. So we'll begin with just setting the scene with some health inequalities that are known in regional and rural populations, and then having a look as to whether there are similar inequalities in AMS and breaking that down to process and outcome indicators. Briefly touching on some barriers to AMS, and then looking at some models that have been published in the literature at least relating to overcoming those barriers, and then touching on the NCAS research strategy to conclude. So there is mounting evidence that there are inequalities for people who live in rural and regional areas in relation to their health, and this is particularly important because a large number of our population live in regional and rural areas, and that's been estimated at 30% of the population. So a third of the people potentially in this audience live in a regional or rural area. The Australian Atlas of Variation in Healthcare was released in 2016, and that really is a pivotal document that outlines a number of health inequalities for rural and regional people, particularly reduced uptake of health promotion activities such as bowel screening and increased rates of preventable hospital admissions in remote and very remote areas. So it's certainly a document of having a look at if you aren't familiar with it already. But specifically looking at cancer, and this was some information that was published in the MJA in 2014, and it indicated from the study that was presented, that was data from 2001 to 2010, that if you lived in a rural area, if you contracted cancer, there was an extra 9,000 deaths in a rural or regional area compared to people that lived in metropolitan areas. So I hope you'll agree with me that 9,000 is a significant number of people whose health has potentially been impacted by just where they live. There's two figures there that relate to prostate cancer, indicating that you have a poorer survival if you have prostate cancer and don't live in the metropolitan area. And the one from rectal cancer I thought was particularly interesting as well, in that relating specifically to your distance from a major metropolitan centre increases your risk of mortality by 6% for every 100 kilometres. So that's a really interesting statistic that came out of that paper. Most recently here in Victoria, the Victorian Government commissioned a study into the preventable neonatal deaths at the Djerriwarrh Health Service, and Professor Duckett was involved in this particular report. It was called Targeting Zero, and it was released in October this year. And there were some very interesting points that came out of this particular paper relating to the capacity of small hospitals to be able to provide good clinical governance, particularly their hospital boards and their capacity in terms of the types of people that were being represented on the rural hospital boards, but also some of the differences in legislative requirements. So from what I've read, city hospitals, there's a limit on a position on a board for 9 years, whereas in a rural hospital you could essentially be on that hospital board for 20 or 30 years. And I suppose it's that refreshment and that new blood that may not necessarily be coming through those boards. This report also suggested that there were some doctors that were resistant to change in rural and regional areas, and there certainly was concern from the people they spoke to about upsetting the specialist in town or the doctor in town, saying that they would move elsewhere if they were required to change certain parts of their practice. So I'm sure that is something that you may have heard throughout your journey through AMS as well. But having said all that, they are great places to live, work and relax. So lovely picture of Ballarat there with this historic building. So don't want to put you off living in regional and rural areas. There's certainly some advantages, but there certainly are some challenges as well. Moving on to AMS process indicators, this is some data from James et al. That was published in 2015. And this was really a needs assessment that was done of some rural hospitals, 11 hospitals in rural and regional areas throughout Australia, looking at what elements of antimicrobial stewardship were in place in that hospital. It is important to note that this study, the data was collected prior to the introduction of the new hospital accreditation that required some of these elements to be in place. But the data really highlighted that a number of these hospitals weren't going to meet the accreditation requirements based on their current structure, and that there was a lot of work to be done to get them to have some of the core elements for AMS in their hospitals and functioning effectively. Given America is a bit of a theme today with the election, I'm glad that I had some American data to include, and it does suggest that there are similar AMS inequalities in American facilities as well. It is important to note that some of the terminology that is used throughout the publications can vary, and the key measure of an antimicrobial stewardship program can change as well. So a fully compliant program has a definition of a pharmacist and a physician who work on the team and provide post-prescription review or pre-authorisation. The CDC core elements is also used in the definition. Other times it's just simple measures such as do they have access to an ID physician, do they have a program as such. American hospitals do differ as well. There's community hospitals which can be quite large or can be quite small, and they also have critical access hospitals which are less than 25 beds, but they're required to maintain a 24-hour emergency department. So there's lots of figures on that slide, but if we just take the one in the middle, the POLAC data being the most recent, that 18% of their critical access hospitals were not implementing all of the CDC core elements for AMS programs, compared to 43% of acute hospitals. But going further from the data that was presented in the from the POLAC survey, probably the most uplifting thing from that was that there were a number of smaller hospitals that were implementing all of those CDC core elements for antimicrobial stewardship. So there were 290 hospitals that had 50 beds or less, albeit self-reported that they were implementing all of those requirements, and in the range of 51 to 200 beds there were 611 hospitals. So that's really positive for us here at NCAS. It reminds us that there are hospitals out there that have been able to achieve the core elements, even in the possibility of them having limited resources, and they're the sorts of sites within Australia that we also want to explore and find out how they've been able to achieve. Moving on to AMS outcomes, and I have used the word outcome a little bit loosely, so I hope you'll bear with me for that. Just was presenting some data from the NORSE program that was in the ORA report that has been mentioned earlier today. And the key figure that's highlighted there is that small public acute hospitals, of which there were 15 that contribute their data, they actually had the highest median antimicrobial defined daily dose per 1,000 occupied bed days. But also very interestingly, they had the greatest range. And you can see there from 312 up to 1,700, which is a massive range for DDDs to be different between those small hospitals. So this data really highlights that there is great variation in antimicrobial use, and that potentially small hospitals are not the same and may need different strategies for AMS. Just noting that small public hospitals may not necessarily be located in regional and rural areas, but there certainly are a large proportion of them in that geographic regions. This is some NAPS data from 2015 that will be available shortly through the NAPS report. 118 regional and 10 remote facilities participated. And this data, it is interesting to look at, and particularly to look at it in comparison to the 2014 data that is available. What I've got up on the slide there is obviously just a snippet, but it is referring to the appropriateness of prescribing, or the flip side, the inappropriateness. And you can see there that major cities are sitting on about 74% appropriateness. Inter-regional, outer regional and very remote are below that, but remote are actually performing slightly higher than the major cities. So I think the message from this data for me is that we really need to look at this in more detail, look at the data over a number of years and see what we can work out in terms of trends. So thank you to Yvette for her assistance with these slides, but this is some data from the New South Wales Sepsis Kills program. And what you can see up on the slide there is the area that's marked in red is the local health districts in New South Wales that are predominantly regional and rural hospitals. The ones on the left are those that are predominantly metropolitan-based hospitals. The sepsis program was really trying to reduce the time to first antimicrobial administration in the hospitals, with the knowledge that administration of that antibiotic within 60 minutes would lead to a better outcome for patients with sepsis. If you look at the bars that essentially are the tall towers there, they're essentially all in regional and rural areas, and that's their data from essentially a baseline data before this tool was introduced. And the regional and rural areas certainly were performing more poorly than their metropolitan counterparts. Positively though, after the implementation of the sepsis program, a standardised tool that hospitals could use to make sure that the antimicrobials were being administered within a 60-minute time period. This is just the regional and rural local health districts that are on this slide now, but you can see that they've made some dramatic improvements over the years that this data has been collected, and the majority of these hospitals are now administering their first antimicrobial within 60 minutes and are actually performing better than some of their metropolitan counterparts and the statewide average as well. So I think that's really positive, just to show that it can be done. It can be done in small centres, and it can be done using a tool that's adaptable for those environments. Okay, so just moving on to some barriers to antimicrobial stewardship, and I don't think anything on this slide will be something that you haven't heard, spoken to someone about, or felt yourself working in a regional or rural area, and they're not necessarily linked to AMS either. They are things that impact a number of different specialities or services within rural and regional areas. But access to skilled AMS staff, ID physicians or AMS trained pharmacists, difficult recruitment and retention of staff is a particular problem. The ability to implement IT programs, geographical isolation from large centres, so although there may be some arrangement with an antimicrobial stewardship physician in a metropolitan hospital, there is that accountability there for the service that's being provided, and lack of priority for antimicrobial stewardship. Hospitals are being asked to do lots and lots of different things, and how does a smaller hospital prioritise which of those things is the thing that they can achieve with their resources? I thought some of these quotes were particularly interesting in, they've come out of published papers, and I've highlighted in pink some of the words that I think are particularly important. So the first one is that there's a misconception that a successful ASP or antimicrobial stewardship program is only possible in settings with plentiful resources. The second one, the key words there are that AMS programs need to be adaptable, customisable, and designed to fit for purpose, no matter what the size of the institution. And the last one I really like, it was about not having fear of forming a less than perfect team, so you're not able to get all those people together in the blue book that we mentioned this morning, but fear of not starting is something that could potentially hold some of these smaller facilities back. So now I'll run through the models that have been described, particularly in the literature, and I guess part of today is to find out what's happening on the ground from people who are here from regional and rural sites. So I apologise if I haven't specifically mentioned your organisation, or you can say, yeah, we're doing that really well. That's part of the research, and for being here today is to find out that information from you. But we have heard about telehealth already today, and I suppose I've categorised telehealth into two different types of models. An on-demand service, so there's some information coming out of Brazil about a computer program that GPs can access in their hospitals in some of the more remote parts of Brazil, where they can put the patient data into a computer program, press pin or enter, and that goes through to an ID physician in a larger hospital who then provides them advice back in what they're calling real time about which antimicrobials to use, and they're quoting that their turnaround time is between 3 minutes and 55 minutes for that information. So certainly 3 minutes would be amazing in terms of putting the information in and then prescribing on the chart almost simultaneously. The second category I've got there is scheduled reviews, which is programs where there tends to be someone on the ground looking after AMS on a day-to-day basis, triaging patients, putting the patients together and presenting them to the ID physician once a week or twice a week. And the Goulburn Valley Health system or telehealth system that was mentioned earlier is certainly one of the scheduled categories. The resource requirements really do vary. The Brazil model required the GP to put information to the computer, but no one else was required. The scheduled reviews, as I mentioned, do tend to need someone on the ground doing the work day to day. Some of the limitations that have been mentioned for telehealth is that there is a lack of cost effectiveness data, and there is also a lack of outcome studies. There was one study that I have reviewed that did compare telehealth versus a face-to-face consultation, and did not show that there was any differences in outcomes on mortality or readmission rates based on which service you received. So that's certainly positive for telehealth models, and there will be more information about that coming through as some of these models that exist are evaluated. Particularly in antimicrobial stewardship, the ability, or infectious diseases I should say, the ability to perform physical examinations is something that may mean that you need someone on the ground performing those examinations for you and providing that information through the telehealth facility. The next model I've called a hub and spoke model, and I've got two examples to share with you from the international scene. The first one is from South Africa that was published by Brink et al. In 2016, so very recent information. And they had a network of 47 private hospitals in South Africa, and they actually utilised their existing pharmacist resource to be able to target the 5 areas of antimicrobial targeting, if I can use that word, for their pharmacists to focus on with their physicians and other staff at the hospital. They had an aim of obtaining a 10% reduction in antimicrobial consumption through this particular process, and what they had was a central group who provided outreach support to each of the centres, really in a quality improvement type approach. So they'd set some goals, they'd get everyone together to talk about how they could do it, get them to go off and do it, get them to come back and say how they'd gone, data that also indicated how they'd gone with being able to achieve a reduction in some of these target areas. So I suppose it was important to note with this particular hub and spoke model that there was no actual clinical support provided at a patient level. It is all very centralised, trying to build capacity at the hospital level rather than having a phone service and ringing up and getting advice from your patient. The second one is Dowson, which is from America, the Duke Antimicrobial Stewardship Outreach Network. Similar in some ways to the South African model, but they have AMS liaison staff that work at a central facility. They have about 5 to 8 facilities each that they look after. They perform monthly visits out to the site. They provide a website with education resources as well as policies that can be used for the sites to mould into their own. But one of the key things that really came up with our discussion with the Dowson people was the data analysis that they perform for the sites was really related to them having a connected system for sharing data. And the hospitals that they had involved were all sharing data into the central system, which is something that we really haven't been able to achieve here that happens on its own. It is very much a manual process in terms of the data that's submitted into some of our databases. So an Australian example that I have listed there is from the Illawarra Shoal Haven Local Health District, which is in New South Wales. They do have a hub and spoke model, centralised AMS education, centralised AMS committee. They do provide outreach visits to their smaller hospitals, and they also have a mentorship program, which I think sounded very interesting in terms of, again, building that capacity at the smaller hospital level. Okay, the next model is an ID physician-driven model, and again I've broken it down into 2 categories. Mobilising an existing local AMS physician, which might sound a bit strange perhaps in the Australian context, but there may be AMS physicians or ID physicians out there who are focusing on one part of their practice, and it's bringing them into the scene of AMS and encourage them to take that sort of role in with their other ID physician activities as well. The second one is using a contracted external person, so I have called that fly in, fly out. I hope that's okay. I don't know if it's just for mining, but that's someone who comes and spends the time at your facility, does the jobs that needs to be done, and then returns back to their home facility. So the key points that were brought out from these studies about whether these models work or not is that they're certainly cost and time effective to use an existing resource or to pay someone to come for a certain period of time. But particularly they mentioned about the ability to build trust, and that takes time, and not to evaluate your AMS service too soon, to allow the person who's coming in to build that trust with the staff there, then evaluate the program in terms of how it's been going. And then there's a bit of a dynamic discussion about whether physically travelling to a site gives a feeling of more commitment to the people receiving the service. Wow, you got in the car and you drove 2 hours. Some of the people here who come from places 3 or 4 hours away or jumped on a plane certainly shows commitment to the cause, versus using an electronic health record, which in some way aligns with the telehealth model. Could we achieve this just by looking at the records rather than physically coming to the site? So that's an interesting discussion that I'm sure will continue. A generalist-driven model is a model where the person that is leading the antimicrobial stewardship at the hospital does not necessarily have specific training in infectious diseases. And the quote that I've got up there on the slide is from a humanitarian hospital in Amman in Jordan. So certainly in an area dealing with the effects of war and limited resources. And what they did was they introduced an antimicrobial focal point, which I thought was a great term for this particular person. They weren't given any extra EFT to do this, but they were actually remunerating this person at a higher level. And the key success factors that have come out of these generalist-driven models is that you still need someone who's ultimately responsible for this, but it may not necessarily need to be an ID physician if you don't have access to one. And really that there needs to be a willingness to share decision making. So the surgeons at that hospital need to be willing to share the decision making with this person who's got this responsibility for AMS. But then we also need to think about who's providing the training to the generalists that are providing the service. Pharmacist-led models, so that can range from a basic model where pharmacists, and this may sound like day-to-day practice for some, but in some hospitals it is just looking at culture reports and matching that up with the antimicrobial that the patient is on. And was that a question? So basic antimicrobial knowledge was all that was required in that particular model. Moving to a more advanced model where pharmacists are actually able to substitute broad spectrum antimicrobials for more narrow spectrum antimicrobials where that's appropriate, and also make dose adjustments as appropriate for renal function, that sort of thing as well. So certainly the advanced model is not something that I've seen here in Australia, but certainly reported overseas. We mentioned nurses earlier today, and I certainly agree that they've really got a frontline opportunity to influence prescribing, and they also have a really important role in infection prevention and infection monitoring. Their role really is still undefined, but there's certainly a lot of work happening to make sure that that role is defined and supported within healthcare facilities. And I've just thrown in project manager here because there wasn't really anywhere else to put it, but there was an interesting paper where they actually employed a project manager to run their AMS program. They did the data analysis, they did the communication, they did the website, they did the newsletters, and it allowed the clinically trained people to spend their time with the patient rather than worrying about some of these other elements. So that was just something interesting to consider. The last model that I have is an embedded model, and this is really a model that challenges us all to say, well, antimicrobial stewardship is business as usual. This is something that we should be doing every day, and you may not necessarily need a specific program per se within your hospital. This is just something that needs to be part of our practice. So there is a US Institute for Healthcare Improvement and CDC collaborative, and the 3 things that are up there are the 3 targets that they're looking to embed into practice. So the first one was improved documentation at points of care, so the indication duration, which is certainly something that we talk a lot about here. A 72-hour antimicrobial timeout, so stopping with the pharmacist to say, okay, is this antimicrobial still appropriate? And improved guideline clarity and access to guidelines, which then hopefully would flow on to increased usage of guidelines. So the data on that is still coming through, but essentially they talk about small, meaningful changes being the most successful and those that don't disrupt people's daily workflow. That the AMS champions that they chose to try and embed those particular things into practice were practicing clinicians and were able to set the example and to show other people, well, I do what it is I say I'm doing, and that the communication back in terms of feedback was real time and it was one-on-one with the person involved, rather than a report that came out quarterly that really wasn't specific to anyone. And just to finish off this part of the presentation, general practitioners, quite a lot of them service rural and regional hospitals, and the organisations such as the MPS are doing a fantastic job educating GPs about community prescribing issues, but there may be a gap about the education for GPs related specifically to hospital prescribing, and we need to consider how we might engage them in hospital programs and hospital education relating to antimicrobials. Okay, so just to conclude, just to summarise the research that will be emanating from that information that we've been able to gather so far about regional and rural AMS. And the quote that I've got up there, again, I thought was quite interesting, that really describing antimicrobial use in smaller facilities is the first step to being able to understand how to implement effective AMS programs in that setting. So that leads on to the first bit of work that we'll be doing, which is looking at the NAPS data from 2014 and the data coming in now for the 2006 analysis, and trying to look at some trends in regional and rural hospitals, try to look at what resources might then best suit those trends. And some of the earlier data certainly does suggest that community-acquired pneumonia and cellulitis are the most common conditions that are treated in regional and rural hospitals, and some of the people that I've spoken to today certainly confirmed that as well. And with some smaller facilities, they certainly are mixed with aged care beds and hospital beds, and the same person managing those beds, the same nurses, the same doctors. So how do we look at that? Secondly, we want to explore some of the sustained AMS models that are in place here in Australia. I've given lots of examples from the literature, but we want to find out what's happening here and what people have been able to do and how it's been sustained. So we'll be doing some qualitative work, key informer interviews with key stakeholders, trying to find out what's been successful in the regional rural environment, what else might you need, and what else could NCAS contribute to make sure that these programs are sustained and enhanced where they may need to be. So hopefully having some information on that in June 2017. Both of those bits of works will then lead to us looking at some models for antimicrobial stewardship in regional and rural areas to help the hospitals work out exactly what it is that's going to be most effective in their environment, and also helping jurisdictions and organisations such as the Commission to put that sort of information into their implementation documents, develop support packages in areas of most need, and where possible evaluate some of the existing models that exist as well. So that's the conclusion of my presentation. There is a few acknowledgements there that I'll let you read, and I also have a number of references, so if anyone was interested in any of the papers behind any of the models that I've described, I'll be more than happy to share that with you. Thank you.
Question from Trish.
Yeah, I've got a question from our webinar. What is trend from Cairns? There's a question in the data from the North, the variation in the small hospitals. Was that more just poor quality of data rather than maybe a true reflection of what's actually happening?
Look, I probably can't comment on that. I don't know if there's anyone in the room that has more experience with the North data, but potentially it is a usage outcome, and that needs to be extracted from different pharmacy systems generally, and that can be quite difficult to achieve. But does anyone else in the audience have a comment about the North data? Thank you.
I looked at a lot of the non-competitive sites, and
You shout.
to answer Trent's question, we are looking at a lot of the non-North contributing sites at the moment in Queensland, and the variation has been historically, it seems to be incorrect and due to dispensing errors or whatever else. We're slowly working through those, and it seems like actually quite real. So the range that this currently quoting could be in actual fact a lot more. And it's working through those processes about the validity of the data and how it goes in, and then what that means for quality improvement processes. And I guess that's the feedback goal at the moment.
Right, thank you.
Anybody else comments about rural regional?
Very rural and regional, I find that we have a massive array of inequalities and enrolled in ourselves, because we don't have any in-house pharmacy, so doctors will bring anything they like and get it in. So there's not a lot of controls for small places that don't have indoor pharmacy on site.
So thank you, that's an excellent point. And Yeah, I know at Ballarat we do supply a number of small hospitals with antimicrobials, and I guess if they order it, we supply it, because our arrangement really is just a supply arrangement, and that's something that we'd like to work on as an organisation or through ANCAS to be able to provide a little bit more support for the things that we are supplying through those arrangements. So I imagine they come from community pharmacies. Is that where the products are ordered through?
A variety, so community pharmacies, other hospitals, and then a multiple health to get to that.
Okay, yeah, sure, yeah, wholesaler. So yeah, that's really interesting. Thank you.
Anybody else before we go in the break? We're opening 10, so quick break, 15 minutes I think. Is that like that?
Yep,
15 minutes. So going to take 10 time speech and then we'll ask for the presentation.
Everyone, I've been instructed to start. One way or another, last one is. Oh no, I've done the wrong thing. Okay, I am the first of two Lesley speaking to you today. The other, I'm Lesley Dowson, and will be shortly followed by Lesley Hawes. I am the PhD candidate looking at AMS in long-term care facilities for NCAS. I'm going to just go over a few definitions about long-term care because that can be confusing and it can get quite muddled in the literature. I will talk about the overview of the problem in long-term care. I'll give you some, sorry, we just have an issue with GoToWebinar. Minor technical delay. All right. Okay. Everyone's back online now. I'll talk a little bit about the problem, which is specific to aged care homes or long-term care facilities, some of the antimicrobial stewardship targets, and two of the projects that are currently ongoing that we are looking at to try to implement some interventions that will help with improved antimicrobial prescribing in long-term care. Sorry, this now isn't going.
It's on the screen.
And there we go. Yeah, lovely. So long-term care facilities can be a confusing term, particularly in America. It can cover both subacute hospitals and sometimes, in fact, long-term acute hospitals. In Australia, we do have this difference in that those particular health service providers are incorporated under the Health Services Act, whereas we have residential aged care, which is incorporated under the Aged Care Act. And in Australia itself, we like to use a range of terms to describe residential aged care. Very popular they are residential aged care facilities or residential aged care, and the Commonwealth has recently moved to the term aged care homes. So that is what I've chosen to use throughout my PhD. So an aged care home is usually a standalone facility. Sometimes they are affiliated with a health service. They're usually serviced by GP prescribers primarily, but the care in an aged care home is primarily nurse-driven.
So what do we know about antibiotic prescribing in aged care homes in Australia? We know that in a study of 5 Australian aged care homes over a 26-month period, nearly 40% of the antibiotics were not for indications meeting the McGear criteria. Now, the McGear criteria is a consensus criteria for infection surveillance and is commonly used in long-term care facilities as a proxy measure for appropriateness of antibiotic prescribing. And this is the criteria that they use with the Aged Care National Antimicrobial Prescribing Survey, ACNABS. So I will speak about some data from the 2015 ACNABS, but our infograph at the back has some of preview data that is available from this year, so I encourage you to go and have a look at that. And what we did find out last year from the ACNABS was that nearly 67% of total antimicrobial prescriptions were judged inappropriately, and of that, 1 in 5 were for residents who did not have any signs or symptoms of infection in the week prior to the start date on their prescription. So this is a problem we've talked a lot about, and I'm sure lots of you here know about the increase of selection pressure for multi-drug resistant organisms that this can cause. But particularly for aged care homes, they have recently been identified as potential reservoirs and gateways for multi-drug resistant organisms into the community and into health services. This reference I have up here of Van den Doel and colleagues, this came out in the Netherlands where they completed some modeling which really explained and highlighted how aged care homes can drive and sustain multi-drug resistant organism outbreaks across health networks. For a long time we've known that antimicrobial use, particularly prior fluoroquinolone use, has been associated with multi-drug resistant organism carriage in residents. This has come from data internationally and from data right here in Australia. We also know that antibiotic use risks C. difficile-related diarrhea, allergic reactions, and other medication adverse events, which can include things such as nausea and appetite loss, which can cause significant stress for both residents and family members of aged care home residents. Work that came out of Canada was published at the end of last year by Nicholas Damon and colleagues. What they did was they were able to stratify high-use, medium-use, and low-use aged care homes as far as antibiotic use. And they were able to demonstrate that in the high-use homes, the residents, whether or not they were taking antibiotic at the time, so including residents who are not currently on an antibiotic, were at greater harm and a greater risk of harm, from having the carriage of a multi-drug resistant organ, from Hep C. difficile, an allergic reaction, and other medication adverse events. So we do know that inappropriate harm of antibiotics can directly harm aged care home residents. There's several factors about why there is inappropriate antibiotic prescribing in aged care homes. Health system factors such as lack of access to infectious diseases physicians, and the fact that diagnostic equipment in radiology and pathology is usually off-site. We do know that identifying the signs and symptoms of infection in aged care home residents can be difficult. Up to 50% of residents do not have a fever and localized pain response, which is the classic sign and symptom of infection in younger adults. Instead, they get vague and atypical yet inconsistent signs and symptoms such as delirium and falls. And this means that the care relationship that the person who is living in the aged care home has with the care providers is critical, because those care providers we are relying on them to be able to identify what is in fact a sign and symptom of an infection and what could just be a delirium or a fall. Certain aged care homes, not all, do have high turnover of staff, which can make that even more difficult. Further to that, we do know from research that there is intrinsic factors with the care providers themselves, such as they can be overly cautious of vulnerable residents becoming unwell, which can lead them to inappropriately prescribe. And we also know that they develop habits. So some just do what they've always done just because that is what they've always done, and not necessarily because it adheres to any guidelines. Further to that, in Australia, advanced care plans and some next of kin have been highlighted by providers of aged care as driving some of the inappropriate antibiotic prescribing. This is here in Australia as well as overseas, the three most commonly encountered indications for antibiotic use are urinary respiratory RTIs and skin soft tissue and mucosal infections, and again that was highlighted in the ACNAPS data and is also fairly consistent overseas as well. When we did the literature review to try to decide what exactly we were going to try to do to put in an intervention or try out an intervention in some of these aged care homes, we found 17 papers on optimizing antibiotic use in long-term care facilities or aged care homes, but interesting, not all of them had primary AMS aims. So there's a group of guidelines from the United States of America, the nursing home acquired pneumonia guidelines, and they were looking particularly at time to antibiotics. So they weren't judging yet whether or not those antibiotics were appropriate. They were just trying to get better adherence to the time requirements. What we did find, though, is that there's significant education interventions. The interventions are often bundled. So, for example, there was some education, but then there was also another tool. One that was more robustly studied was an algorithm for UTI diagnosis and treatment. And some of them looked at broad areas, and some of them looked at clinical area or single clinical areas. But ultimately, the literature review really showed that there is no single AMS intervention that can yet be recommended above all others for Australian aged care homes. However, we used the data from the ACNAPS as well as the analysis of the gaps and opportunities and concluded that respiratory tract infection and antibiotic use in end-of-life care are in areas in need of further support and evidence for future interventions. I'll just make a quick comment about UTIs, because UTIs prescribing an aged care home is usually the hot topic, and there might be questions about why we haven't focused on that. I personally haven't focused on that, but with the resources and what ACNAPS is doing, as well as there's some resources coming out of a group in South Australia that will be focusing on UTI in the near future. So it's really the analysis of the gaps which led us to believe that we should be focusing on something else, because there's nothing else currently available for respiratory tract infections. So that brings us to my first project, was optimizing antibiotic use for respiratory tract infections in aged care homes. And again, from the 2015 ACNAPS, we saw that nearly 70% of RTI antimicrobials were for indications not meeting the GEAR criteria. And of that, less than 11% that were treated with antimicrobials had specimens collected for microbiological investigations. This was the second lowest, next to eye infections, for specimen collection. Having said that, the therapeutic guidelines are actually quite clear in recommending rapid specific microtests on nose and throat specimens for the assessment of community-acquired pneumonia in adults, the assessment of pneumonia in residents of aged care homes, as well as influenza-like illness. And interestingly enough, this letter was written by the Acting Chief Health Officer of Victoria in April of this year and sent out to all residential aged care providers, asking for standing orders for multiplex respiratory PCR to be put into aged care homes during the influenza season. So that is what we have tried. Just quickly, multiplex respiratory PCR is essentially a nucleic acid amplification test where we can look for all of these viruses and some atypical bacteria. This is the assay that we are using for our test. You can get different assays depending on where you are sending your specimens to, but it is something that is readily available in all health services as well as all private pathology labs to this day. So we thought that we could improve the use of antibiotics not meeting the established infection surveillance criteria. We could decrease this in we could decrease inappropriate antibiotics if we were able to promote this use of the routine micro-investigations to try to try to diagnose viral infections. So up to 39% of serious lower respiratory tract infections in older adults is viral etiology. Viral pneumonia is uncommon in younger adults, but it increases with older age. So what we did was exactly what the Victorian Chief Health Officer asked, is that we put a standing order into our 3 sites for respiratory PCR, and we trained up the RNs at the site to take specimen collection, and part of our protocol is that the RNs are to notify the GPs whenever they are taking a sample, as well as notify the GPs of any results that they receive. So we're working now at 3 sites affiliated with the tertiary healthcare service. We have 181 beds, and we're actually looking at extending our intervention phase at this time, but initially we were looking for 6 months, as well as doing some post-study interviews with GPs and the nurses to see if this was acceptable. Little bit of just before data from our sites. They actually came in a little bit better than the point prevalence survey that we were given from the ACNABS data, but there's still 50%. So 50% of the antibiotics that they prescribe for respiratory tract infections are judged to be inappropriate. Quick update, we're not even at a quarter of the occupied bed days that we are expecting. So far we've had 11 swabs come in, and all the results so far have been for rhinovirus and enterovirus, or none detected. We've had to do a few investigations about this none detected, and we will have to explain that in our results, but we are confident that it's not an issue with sample collection. So the nurses are quite competent and able to collect the samples and have them appropriately delivered to the pathology lab. I have up here, none of the swab residents have yet received antibiotics for their RTIs. I had to send this presentation on Monday. I was out there visiting it yesterday, and we now have had a resident who did test positive for rhinovirus and enterovirus. And after 7 days after he didn't improve, he was written a script for antibiotics. In addition to that resident, we do have a number of residents who have been written scripts for their antibiotics, but written script for antibiotics for respiratory tract infections, but they were in fact never swabbed. And this is the case of Mrs. F. And she is a woman who was in her 80s who actually appears 3 times in our data collection for antibiotic prescribing. She was living in one of our pilot homes, and she had advanced dementia. 2 weeks after the beginning of the pilot, she had what was listed in her record as a known aspiration event, and she was given a course of antibiotics. The following month, she had listed in her resident record a likely aspiration event, of which she was given 2 escalating courses of antibiotics. Mrs. F unfortunately did not recover, and Mrs. F actually passed away in one of our pilot homes in September of this year. Now, of course, every life and death is unique, and so was Mrs. F's, but this sort of escalating pattern of antibiotic use towards the end of life is something that we do commonly see in aged care homes. And that leads us to the second project and the second area that we are going to try to target, and that is antibiotic use at end of life. So antibiotics are extensively prescribed in the last month of life in aged care homes, especially the 2 weeks before death. We know that the number of antimicrobials, the days of therapy, and the number of residents on antimicrobials increased significantly in the 2 weeks before death. We also know that there are a significant number of residents of aged care homes who do in fact die while living in an aged care home. So more than 94% of life separation from aged care homes are due to death. And from the last year that we have data, it was nearly 56,000 residents of Australian aged care homes died. One of the reasons behind the current initiatives which aim to avoid hospitalization, especially in this subset of residents who are end of life, are the perceived harms that taking somebody out of a familiar environment poses to residents when you take them from where they know and from where the carers know them and take them into acute hospitalization. So what this means for end-of-life care is that caregivers within aged care homes are increasingly being encouraged to actually deliver high-quality end-of-life care in the aged care homes themselves. Other than that, we don't know a lot about what is happening at this point in time with antimicrobial prescribing. We don't know whether or not they're being given to residents for perceived symptom relief, or whether it is an effort to prolong life, and we don't know whether or not the potential harms that antimicrobials can pose on quality of life are considered during this time, when end-of-life care is usually seen as a point in time when you're trying to maximize the remaining quality of life that somebody has. Really, really importantly, there is this very robust body of evidence that comes from palliative care about the ineffectiveness of antimicrobials at the end of life to either increase longevity of life or relieve symptoms, except for with a few circumstances. And that body of evidence is continuing to evolve in aged care homes themselves, particularly in residents who have advanced dementia and end-of-life pneumonia. So we know that antimicrobials do not prolong life. We know that antimicrobials do not provide symptom relief in this particular demographic. But, and it's an important but, not all residents of aged care homes are at the end of life. There are residents of aged care homes who live for decades in relatively well health in aged care homes. And so what this does is adds to the increasing complexity of prescribing that we're asking for GPs and other caregivers in nursing homes, in aged care homes to provide. And when you look at the guidelines and what the guidelines say about this, this is from the antibiotic therapeutic guidelines, from the outset established whether an advanced care plan is in place and whether antibiotic treatment is appropriate for a particular patient. So you get this idea that there maybe is this group of residents or group of people that antibiotic prescribing is not appropriate for. But if you look at the therapeutic guidelines, this is kind of the beginning and the end of the advice that they are providing. So what we are trying to do is put some framework around that and to help with this, to help the aged care sector provide quality end-of-life care. And at the same time, we should be able to reduce some inappropriate prescribing. So first step is to talk to some health professionals as well as the residents and their next of kin on antibiotic use at end of life in aged care, what they want, what their experiences are. We're looking to determine some perceptions and some AMS initiatives, initiatives that are derived from things that have worked in aged care homes elsewhere, and whether or not they would be acceptable, but really get a sense on what the sector themselves would want and what they think they could benefit from. So it's a qualitative exploration. Health professionals are interviewed as individual, residents and their next of kin are interviewed as dyad, so a group of 2, and we're looking at health services and agencies around Victoria. And just quickly, because I am running out of time, but the first output that we are hoping to do is actually describe what we mean by optimal prescribing at end of life in aged care homes, because all of these different specialties have bits and pieces from different guidelines. Where they kind of touch on in passing, again, similar like the therapeutic guidelines, that there is this group of people that it might not be appropriate to prescribe to, but is not anywhere in one concise place. So that is one of the first steps we're doing in this project. And just to give you a little bit of the direction of where we are going, in Oregon, then they have this really fantastic vet care directive, which is called a physician order for life-sustaining treatment, and antibiotics is one of the things which is featured on that document. So if you look down at the bottom 2, those are the numbers of people who have actually written on their physician order for life-sustaining treatment that they would like to limit antibiotics to only those that could provide symptom relief. If nothing else can. And so there is a significant portion of the population who would forego antibiotics, and it would be their choice to forego antibiotics. But again, we don't know where that sits in Australia and whether or not that's something that's being looked at and it's something that's being asked. So that's just a little bit of the direction we're going, and I just want to thank everyone from here and as well as from Monash.
You're looking at people from different language, cultural, religious backgrounds.
They wanted to know whether or not we're looking from different religious, cultural backgrounds. We are. We haven't particularly sought out to sample that. We're trying to get, I guess, a broad sample, and one of the things we are particularly looking at is not necessarily particular religious backgrounds, but we do ask quite up front of whether or not you have a religious belief or other belief which focuses or believes that the sanctity of life or longevity of life prevails all suffering. So I guess we're trying not to look at necessarily at like religion specific, but more like personal beliefs that people have. So we are trying to get a sample of people who, you know, are looking for longevity of life over, say, quality, and people who are more interested in quality of life over longevity. And I mean, it will be different for all of us.
Okay, welcome everyone. I'm the other Lesley with an EY. To introduce myself, yes, I'm up there. I started my career as a hospital microbiologist, and I still teach microbiology here in this very room. A few years ago I moved also into quality and safety. I'm a sessional teacher, but I moved into quality and safety, coordinating a GP-led clinical risk management program for GPs working in Victoria's rural hospitals. So what Jaclyn had to say was very interesting to me. But after that was sadly defunded, I completed my Master of Public Health and worked to support the education of medical students being placed in general practice. But when this PhD opportunity came up earlier this year, I thought it a beautiful fit with my loves of general practice, public health, medical microbiology and risk management. Now, I only started 15 weeks ago, so I'm the baby of all the PhDs. And so I'm going to be presenting the background to antimicrobial stewardship in general practice and what we know about the situation in Australia and where my PhD will fit in. Now, click that one, I take it. Keyboard? Okay. There we go. So first of all, as you've been hearing, use causes resistance. But what about in primary care? Systematic reviews have showed that individuals prescribed an antibiotic in primary care for a respiratory or a urinary tract infection develop bacterial resistance to that antibiotic. The effect is greatest in the month immediately after treatment, but may persist for up to 12 months. That's a year. So if you're given antibiotics in general practice, your bacteria may become resistant for up to a year. It's quite scary, isn't it? And of course, the longer the duration of treatment and the more courses a patient has, the more resistance can develop. Now, I'll be using these examples of respiratory and urinary tract infections in my talk as well. We've been hearing about them in other talks, but they are quite common in general practice. So how much resistance do we have in the Australian community? So from that AURA report you've heard about, I've taken out some figures for urinary tract infections. Urinary tract infections in the community, E. coli, E. coli, E. coli is something we teach the medical students. They're nearly all caused by E. coli. I can see my colleagues smiling over there. We no longer use ampicillin to treat. They're 40% resistant. And the first generation cephalosporins and trimethaprins, 1 in 5 are becoming resistant. Norfloxacin is used to treat resistant strains. We're starting to see resistance to that in the general practice community, and that's us. Staph aureus I thought I would put in. That's a very common infection. If you've had an infected cut, wound, sore, boil, abscess, Staph aureus is likely to have been implicated. We just don't see penicillin-sensitive ones anymore. And circulating in the community, 11% of them are the methicillin-resistant or MRSA or golden staph. And those respiratory tract infections, well, your common colds, coughs, sore throats, they're viral in origin. Antibiotics do not treat viruses. And of course, if you take antibiotics for a viral infection, you're not really affecting the virus, but you're increasing the chances of your microbiome becoming resistant. So let's have a look at general practice. 87% of us visit a GP at least once a year. So most people in this room would have been to a GP probably in the last year.
For every 100 encounters, the GP has to deal with 155 problems. This is 10 more than 10 years ago. So we are becoming more complex as we get older. We're getting more chronic disease. And in those 100 encounters, the GP is dealing with 23 infections. And as to antibiotics, 46% of us had antibiotics prescribed. So 1 in 2 of us, so if you turn to your neighbour, one of you, the 2 of you is likely to have had antibiotics in the last year. The top 3 prescribed: amoxicillin, cefalexin and amoxicillin clavulanate. But surprisingly, the total is 30 million prescriptions of antibiotics a year. 30 million. We're a population of what, 23 million? And half of us take antibiotics. Someone's taking a lot. So just pause to think on that. 30 million prescriptions for antibiotics written in general practice a year. This is where the bulk of human use is in general practice, primary health care. So this is where we need to look at what's happening. So how do we compare with other countries? Again, from the oral report. This is per 1,000 inhabitants. We prescribe more than the US, we're still voting, or are they finished now? England, Scotland, Canada and Sweden as listed on this chart from the oral report, but also Denmark, Norway, Netherlands and Germany. So we are very high prescribers. So my PhD is aiming to look at what antibiotics are being prescribed for what conditions. We do know there is variation with patient age. Younger and older people have higher prescriptions, and we know the prescription rate goes up with lower socioeconomic status, and we do know there is some geographic variation. I'm also interested in looking at what's being prescribed for what and comparing it with the guidelines. And being a microbiologist, I'm interested in, of course, pathology results. So I'm interested in the culture and sensitivity. So do we have resistance out there in these practices you'll see in a moment? And also what point of care or rapid testing is being done to help GPs with their diagnoses. So to do this, I'm going to look at some database analysis. Now, just a word of explanation. You've been hearing about hospital data, but in general practice it's a bit more like veterinary data. GPs have their own software, they keep their records there. There's not linkage like there is in hospitals. So we're a bit more like the vet practices here. But we're starting to link some of their data. And I think Dougie's gone, hasn't he? Yeah. Anyway, one of the databases that I was going to start with is the Magnet database. This is a database of 50 general practices across Melbourne's east. They cover different socio-economic groups in there, and the total pool, it's been going for about 10 years, and there's a total pool of 1.1 million patients in this database. And I'm going to be looking at 5 years data from 2010 to 2014. Then I'm hoping to interview GPs about the patterns of use. What are the drivers? You saw the earlier questions. Why are they prescribing? How do they select? Similar in mine as well. I'm also interested in their experience with antibiotic resistance. Have they had a patient that they've had difficulty treating, or have they adjusted their practice at all to account for any the perceived threat of antibiotic resistance, for instance? So let's have a look at what we already know. GPs do know resistance is a global problem, but interestingly, 2 out of 3, 67% did not believe resistance was a problem for their practice. But you saw the earlier figures. There is resistance in the community. Almost all GPs think excessive use is responsible, but that it's patients not adhering to their treatment that's responsible. So there's a bit of interest there, whereas we know it's any use contributes to resistance. Now, what about patients? As a community, we're not doing well, and as a scientist, we're certainly not doing well explaining resistance to the community. So if some of that data has left your head in the whirl, you're not alone. 88% of the community, so that's most of us in this room, would believe resistance is something the body develops. People talk about, I am resistant to the antibiotic. They don't understand it's their bacteria, but I'm at low risk. It's someone else's fault. And so therefore, strategies to reduce antimicrobial use should be targeted at the doctors, not me. And as I said, we're unaware of transmission. We don't realise that the resistant bacteria can be spread via the environment, that bacteria can spread their genes amongst each other as well. So we've got a lot of explaining to do in the community as well. Just a slight digression to explain something. General practice is covered by standards set by the Royal Australian College of General Practitioners, and most general practices are accredited to those standards with the Australian Commission of Safety and Quality in Healthcare, and all the practices should be accredited by the 1st of January. Now, criterion 5.3.1 relates to the safe and quality use of medicines. GPs have to use best evidence prescribing, and patients should understand the rationale, the benefits and risks of their medication. So what is happening? We understand, patients don't really understand about resistance. GPs are trying to explain it. We know, if you remember those 100 encounters where the GP deals with 23 infections, they're also giving 39 clinical treatments, which is advice, education, counselling. So we do have some evidence that GPs are trying to explain things to patients. So what actually happens in the consultation? Well, the patient's in front of the GP, that's us. We're sitting there in front of our GP, or if you're a GP, you've got a patient in front of you. And the gold standard of culture, it still takes that 48 hours to get your full sensitivity back. And if I had $1 for every time a doctor said, can you please rush these results? I sympathise. I know you need your results back. But they do take the time. So they're really of not practical help for you dealing with that patient at that time. They are of help later on. Then there's monitoring. In hospitals, patients are monitored 24/7 by trained nurses, whereas in general practice, the patient's with you for a little while, then they go home, and they may or may not have someone home to look after them. They may be a caregiver themselves, or their partner may be at work. And a study found in Germany that more prescriptions were written on a Friday than other days of the week, suggesting that there is this uncertainty about weekends coming up. GPs may not be open, patients may not be able to access the GP, a lot of buses don't run at the weekend and so on. There's also that diagnostic uncertainty. As I mentioned, patients, we're becoming more complex, we're getting older, we're getting more chronic conditions. So at what point does that patient cross the line from not needing antibiotics to needing antibiotics? It can be very difficult to determine. The relevance of the guidelines for those complex conditions. There's very much a focus on patient-centred care, and there is a perceived patient pressure. GPs report it more than patients do, but some patients do want their antibiotics, particularly if they've had antibiotics in the past for an upper respiratory tract infection, so they often want them again. And 40% of GPs have said that they will prescribe to satisfy a patient. And then, of course, it doesn't take many sad news headlines like little Elijah died of meningococcal meningitis. And basically, if he'd had antibiotics, he'd be fine today, wouldn't he? Now, that really does upset everyone in the community, doctors included. And no one wants to miss a serious developing infection. And if you've had a previous bad experience or hear that on the news, it's no wonder people ask for antibiotics. So the outcomes of that consultation now, of people with your upper respiratory tract infection, these are your coughs, colds, sore throats, more than 50% of those will get antibiotics. And as I said before, these are your viral infections. Antibiotics do not cure a viral infection. Repeat prescriptions are some of these are unnecessary, and then the other thing we know is up to 1 in 5 of these repeat prescriptions are filled many months later, which is also not necessarily appropriate. Then there's things like pack size. For an uncomplicated urinary tract infection in a woman, 3 days of trimethoprim is normally prescribed as per the guidelines, but they come in a pack of 7. So does the woman take 3 tablets as the doctor told her and then put the other 4 in the cupboard till next time she or a family member doesn't feel well? Or does she remember, no, I've heard you should always finish your treatment, so she'll take all 7, thus extending her contact with antibiotics and increasing her chances of developing resistance. And as I've already mentioned, prescription rates, dispensing rates do vary between cities and local areas. So something else is going on there as well. So my PhD aims to examine interventions that have already been carried out, looking for the evidence for the intervention, how it was done, what were the outcomes. Some of the interventions are listed here. A lot of them are done in packages. What were judged to have worked and what haven't, and how they were judged on what criteria. So I'll be particularly looking at evidence-based interventions that will address the stewardship areas I've identified in my earlier work. And then I hopefully will be able to develop an intervention that takes into account all of the factors here, my database analysis, GP interviews, reviews of existing interventions. I'll be looking at behavioural science models. I know Courtney's going to talk about those in more detail next, so I'll leave that part to her. We also do have to take into account that diagnostic uncertainty, the patient pressure. We need to give GPs some feedback on their own prescribing. We need to allow them to reflect on their own prescribing as well. And ideally, an intervention should ensure that patients who need antibiotics get, as we've heard today, the right antibiotic for the right dose for the right duration, and that patients who do not need antibiotics understand why they don't need antibiotics, and so that we can prevent harm coming to patients who don't need antibiotics. Thank you. Any questions? Just a minute, I think the microphone's coming. We'll wait for that for the people on the webinar.
Just repeat the questions for us.
Okay, I will.
Thanks for the excellent talk, Lesley. Just if you could perhaps comment on the role of pharmacists in their primary care.
Yeah, that's a difficult one because yes, pharmacy take part in some interventions. GPs prescribe, pharmacists fill. It's unknown really how much a patient, when they go to fill out a prescription, discuss with the pharmacist the need for the medication or not. That is something that I could be looking at with the interventions that have taken place. What is the role of the pharmacist? I think they definitely should have a role for things like those upper respiratory tract infections for which antibiotics are not indicated. There could perhaps be more of a role there for your pharmacist. But again, that's, as I say, I've only just started, so it's something I'm certainly bearing in mind, unless Cass has something she wants to say. Again, with NCAS's support.
You might be referring to some of the movements in the UK with the NHS and their implementation strategy for stewardship, where they're actually formally mentioning that there is a clinical pharmacist based in every primary care sector, and I think we need to just reflect a little bit on how different the NHS is, where it is actually a group attached to a hospital. In Australia, it's a very different situation. They do have the, I think they're called LHNs now. VHNs or something like that. But often there are groups or even single providers, and the structure of our primary practice is very different. Jonathan, did you want to sort of comment? You've probably got quite a few thoughts with the NPS, because I think NPS really are the group that are very experienced in how to deal with actually delivering education to general practice in Australia, and particularly their work in antimicrobial use over just down there. I think you've probably got some very salient insights for us hospitalists.
Oh, just a couple of comments. Well, I guess people tend to go to the community pharmacy 5 to 6 times more often than they go to the GP, so it's a really good opportunity for active education with consumers generally. And so when we roll out our educational programs, we use the community pharmacies as a channel to communicate through the patients. And obviously that opportunity around respiratory tract infections and what's the best management approach there. I think we haven't seen a clear sort of impact through community pharmacy and the uptake of antibiotic use, and I'd like to see how that might improve.
Can you comment on the pharmacy prescriber push in Australia? I think there's going to be pharmacy prescribers, right? Vaccinators and
yeah, I don't have a specific sort of knowledge of where that's up to at the moment, but they're just going back to that idea about having pharmacists working in general practice. There are trials occurring currently in different places across Australia.
Lynnon's got a question, I think. Back right up the top. By the way, the closing, it's, what was it, Kirsty?
197 to 209.
197 Clinton, 209.
I was just jumped to 216.
Oh, bugger, Trump 216.
Thank you. It's Megan and I'm currently working with the Queensland statewide Antimicrobial Stewardship program. And I've just come off working with the general practitioner Antimicrobial Stewardship program, and where we focused in Southeast Queensland. So we specifically looked at prescribers, but we also did a survey on the side because I'm a pharmacist. I needed to, when my pharmacy had, I just couldn't not include pharmacists in the study. And so this isn't part of the information was in the report that we put out on our website. We did survey pharmacists that were co-located with GPs, and particularly targeting their knowledge of acute respiratory infections and what they would do. So many of the pharmacists were inclined to refer to GPs if there was some comorbidities, but I think it also highlighted that in community pharmacy there was a bit of a lack of knowledge of antimicrobial stewardship and the management of even common conditions such as acute respiratory infections. And then another program which Jonathan has highlighted, and I think it's something we with our stewardship hat should really be supporting these pharmacists. The pharmacists that are being put into practices to assist GPs, and they're looking more at chronic conditions. I think they will be ideally placed to implement stewardship programs in GP practices, and many of them haven't even thought of that, and I think it's something that we could support and highlight and encourage them to take on this role so they conveniently located. And the other thing is they're not affiliated with the pharmacy which has that vested interest. That's how they make their money, is by dispensing prescriptions. So you'll remove them from that process.
Any other questions? So we might move on to our, sorry.
Can I give some comments?
Okay. Yes.
My name is Courtney. I've been in Melbourne since 22 years ago. Talking about aged care, my elderly mom, 92 years old, and I used to be very good friend with the Australian elderly lady. What happened was the elderly lady friend she was in nursing home for about 5 years, but she used to tell me how she wished to die at home. But later years, she had memory loss, and she regularly, actually every year, injection of flu. My mother, 92 years old, never took the injection, the flu injection. She has very good memory. Taking a salmon. What I'm trying to say is that aged care it is so important that I hope that government and hospital will try to help the elderly. My mother was hospitalized, but she couldn't take the food in the hospital. One thing I would like to share with you, the last 2 years I did not see any doctor because I discovered the great value of apple cider vinegar. And then you can Google search, find out how useful it is. There's a loving community in the internet. When I did the home remedy search and come up with great information. So, you know, saved a lot of money from taxpayer last 2 years, it's a long time.
Thanks, Connie. Thank you, Connie. We agree with you that there's lots of work to be done with aged care. So we might move on to our lucky last speaker, who is Courtney, who has been doing a sterling job moving very fast in her field of surgical antibiotic prescribing. After the last talk, we can take a few questions, and then you're all welcome to step back for wine and cheese and have a chat and mingle, and hopefully we might have some fun with your West results.
Okay. Good afternoon, everyone. So my name is Courtney Ierano, and I'm a PhD candidate representing the tertiary care stream, which we're focusing on surgical prophylaxis. So who am I? I'm very fortunate to have started my PhD here at NCAS at the end of June, so about 4 months in. And before this, I was an antimicrobial stewardship pharmacist and clinical pharmacist at Albury-Wodonga Health and Young Health Service in New South Wales, which also services Young, Cootamundra, Temora, Harden and Burra, so all regional New South Wales hospitals. So to lead up into my presentation, I'll be talking about my PhD and the research that I plan to do, but also a lot of work from NCAS that has led to my PhD and the questions that I have. So first off, I'll be talking about some data from our most recent NAPS survey. And once again, the most common indication was surgical prophylaxis. And again, it was following previous reports in 2014 and 2013. But not only from that, surgical prophylaxis was also prescribed at the highest rate of inappropriateness at 40.5%, again consistent with other years. Some other findings from NAPS, cefalexin was a common antibiotic that was prescribed inappropriately 40% of the time, and from this surgical prophylaxis was a common indication for inappropriate use. Those reasons for inappropriateness were that there was no indication, incorrect duration, dose or frequency, or the spectrum being too narrow. Similarly with gentamicin, another common antibiotic used, 31.2% inappropriate use, predominantly coming from our private sector, and again surgical prophylaxis was a common indication. Specifically looking at surgical prophylaxis, approximately 2 in every 5 prescriptions were deemed inappropriate, again for duration, dose and a lack of indication. This graph here is from the Australian Orthopaedics Association's National Joint Replacement Registry, and basically it's looking at cefazolin use, which is commonly prescribed in elective joint surgeries. So the first half of the graph in the dark green is cefazolin usage in metric tonnes, and then in the reddy colour that's non-compliant cefazolin use. And then the later part of the graph is projected increase in use of both regular use and non-compliant use. So as you can see, we're using a large amount of cefazolin. A lot of it will continue to increase, and similarly at the rate that we're going, so will the non-compliant use, and also this is just for elective joint surgery. So overall in Australia it will be a lot higher. So surgical prophylaxis is a common indication for prescriptions. A lot of it's inappropriate, and we're using a lot of antibiotics for it. So in response to our NAPS, the Commission and NCAS have put forward a surgical NAPS, and I'll talk to you about some results from the pilot study. SNAPS itself took on a different methodological approach. So NAPS is period prevalence studies, whereas SNAPS takes a longitudinal approach, and by doing this it provides a more accurate picture of surgical prophylaxis prescribing. So NAPS being point prevalence, it only captures the antibiotics used in the day of the study, whereas the longitudinal nature of the SNAPS captures the day of and a 30-day period. So you could be looking at extended post-operative prophylaxis, readmissions, and any other surgeries that occurred in that 30-day period for that one patient. So a broader coverage of surgical prophylaxis. So the SNAPS pilot itself was in May last year, 11 institutions across Australia with 668 patients. Antibiotics given perioperatively and post-operatively were quite similar, or exactly the same, the top 5 for both, and cefazolin again was the most common. But in terms of appropriateness, they did differ at the perioperative use and post-operative use. So perioperatively, 51% optimal use in comparison to 15% in post-operative, and a higher rate of suboptimal appropriateness for post-operative use. For reasons of inappropriateness, so the first column is perioperatively and the second column post-operatively. A lack of indication was the most common reason, followed by incorrect duration in the post-operative phase, and then incorrect dose. The SNAPS pilot data also identified that there was a suboptimal recording of incision time, so only 62% of the time was this documented, and from that 63% of the time it was not accessible. So the pilot data revealed that we're not doing this very well, and it's very hard to comment at this stage. Outcomes were also measured in the SNAPS pilot data. At a 30-day mark, this wasn't a compulsory measure to report to, but from the data that we did get, 10 patients, 1.5% developed an infection, and 9 of those 10 patients received inappropriate surgical prophylaxis. So suggesting that that could have potentially attributed to the infection that developed. So the SNAPS pilot was highlighted lots of areas where surgical prophylaxis is not necessarily going so well, and then following on from feedback from the end users, it was developed into an online tool and was developed for a national implementation, which is our SNAPS 2015-16 data. Now, there was an overwhelming response from 75 hospitals and over 3,800 surgical episodes. SNAPS actually only closed less than 10 days ago, so as you see, that is a lot of data to go through, and the SNAPS team have worked very hard to grab a couple of figures for me to discuss, but a lot of it is still pending further analysis. So from this data, it was identified that 1 in 5 surgical episodes had inappropriate surgical prophylaxis, where it was the perioperative surgical prophylaxis, a third of these were inappropriate, and common reasons were incorrect timing and dose. In the post-operative phase, where antibiotics were prescribed, 2/3 were inappropriate, and again reasons for this were a lack of indication, incorrect duration, dose and frequency. And again, yeah, a lot of work to be done with all this data, and there will be a public report available in a little while, next year. So basically from NAPS, the pilot and SNAPS, we can see that Surgical prophylaxis is an area of concern. We know that it's a common indication, but it's also being prescribed non-concordantly. So who then describes or defines what is concordant prescribing? Fortunately in Australia, we have this wonderful pink Bible as the therapeutic guidelines antibiotic. As part of national hospital accreditation under the Antimicrobial Stewardship Clinical Care Standard, specifically Quality Statement 9, looking at surgical prophylaxis, hospitals should be endorsing the therapeutic guidelines or taking that reference into consideration with their own local guidelines. So we have a situation where where we do have this really, really good reference, but we have a situation where non-concordant prescribing is still occurring. There's been lots of reasons or suggestions as to factors that influence guideline concordance. Well, one of those might actually be the guidelines themselves and the evidence behind them. So as part of my PhD, for part of my literature review, I've conducted a rapid review of the available evidence supporting therapeutic guidelines antibiotic surgical prophylaxis. By rapid review, I know it's not a systematic review. It does have limitations regarding to the inclusivity of its content, but nonetheless, this review has allowed me to identify some generalised limitations of the current evidence. So the current evidence base is predominantly based upon historical studies, so earlier studies from the 60s, 70s and 80s, which by default are less robust as they weren't subject to today's rigorous quality assessments. They're more prone to publication bias, and a lot of them include antibiotics that aren't available in Australia and therefore unapplicable to our prescribers. A lot of the literature for common surgical procedures such as arthroplasty, cardiac and colorectal surgery, a lot of the literature was systematic reviews and meta-analyses, which were all very supportive of surgical prophylaxis, but they couldn't specify any one superior antibiotic, dosing time, duration and so forth. And that's mainly because due to a lot of the papers included in these reviews are heterogeneous. And by heterogeneous I mean they differ in a various of contexts, so the study design, the sample size, inclusion, exclusion, criteria, and again the antibiotics, so different antibiotics, doses, administrative routes, the timings and the frequency and duration. So whilst those studies could say yes to surgical prophylaxis and they couldn't confirm superiority, they then called for further trials and research to be conducted. And then this is commonly seen in the form of level 3 evidence studies, such as non-randomised trials, cohort, case controls, interrupted time series with control groups, which again can't confirm superiority of any one dose or antibiotic regimen because of the lower level of evidence that from their study design. And again, call for more research. So what about all these new randomised controlled trials? Because of the low rate of surgical site infections, to have a really robust RCT in the modern day, we need a very large sample size. And again, because that low surgical site infection rate, we need it to be conducted over a larger period of time, probably involve multiple sites, which might not necessarily be economical or feasible. So that's when we have expert consensus slotting into the mix of things. According to the NHMRC, expert consensus doesn't even register as a level 1, 2, 3, 4, 5, but the Oxford levels of evidence acknowledge it as a level 5 sort of evidence. So again, on the lower end of scales of evidence, and that's important to note because when we review evidence, those sort of criteria come into play. Expert consensus is handy in the sense that it can interpret all these lower level studies within the context of the earlier higher grade quality studies and then provide more meaning to those studies and make it more applicable to our current practice. So Kirsty was here talking earlier about trying to bridge the gap between evidence and actual practice, and that's where expert consensus tries to fit in this gap. And the therapeutic guidelines is developed by the antibiotic expert group to a form of expert consensus. So I guess that's where that all fits into everything. But in saying that, that doesn't mean that it shouldn't be subject to any sort of review like all other evidence. Other things identified in the literature was that there was a lack of discussion surrounding the impact of antibiotic usage. So things like adverse effects like Clostridium difficile, and also microbiological and ecological impacts upon antimicrobial resistance. And as well, most trials excluded critically ill patients and common comorbidities, which are quite common in our primary treatment targets. So again, a lot of the literature might not necessarily be applicable to the people that we would be prescribing for. So all these sort of limitations can be seen as barriers to prescribing, barriers to being compliant with guidelines, because this evidence is what forms part of the guidelines. And then further discussion to barriers, Cabana conducted a systematic review of the literature to identify prescriber barriers to guideline adherence, and they identified these barriers into 7 common categories, and this formed their framework. These include a lack of awareness of the evidence, lack of familiarity with the guidelines, a lack of agreement with the guidelines, inertia of previous practice, a lack of outcome expectancy, a lack of self-efficacy, and external barriers such as patient, guideline, and environmental factors. More recently, Gidengal applied the Cabana framework to establish their own framework of factors and barriers that might influence antibiotic prescribing, but specifically for acute respiratory infections. And by doing this, they wanted to identify drivers and independent predictors of what they called imperfect antibiotic prescribing. So imperfect antibiotic prescribing would be prescribing antibiotics when they're not indicated, or not prescribing when they were indicated, or then prescribing something incorrectly, so incorrect dose, duration, or frequency. And what they did was they assessed some prescriptions from an X amount of prescribers, and those prescribers also completed a survey which measured attributes like knowledge and attitudes and beliefs about antimicrobial prescribing and resistance. And what they did find was that there were 3 common barriers, and it was that they were rushed to prescribe antibiotics. They believed less strongly that antibiotics were overused and that patient demand was not an issue. Overall, the authors identified that predominantly most of the prescribers in this study did believe that antibiotics were overused and that demand was an issue, but they were able to pinpoint it that those who felt less strongly about this were more likely to prescribe imperfectly. And another earlier literature review looked into barriers of evidence-based practice in primary care, and the following factors were identified as barriers: availability of evidence again, relevance to actual practice, dissemination of the evidence in the guidelines, individual motivation, ability to keep up with current changes, the clarity of roles and practice, and culture-specific healthcare practices. So the previous papers I've mentioned, I've all tried to provide some sort of understanding of behaviour, which is important because if we want to change behaviour, we need to understand what's driving that behaviour in the first place. So in this scenario, inappropriate surgical prophylaxis is the prescribing is the behaviour that we want to change, but how do we go about this? There's currently a growing interest in the use of cognitive, behavioural and organisational theories. And this is to provide a better understanding of barriers to implementation. So I guess the implementation that we want to do is to implement better concordance with therapeutic guidelines. And then by having this knowledge, we then hope to inform the design of future interventions to further improve surgical prophylaxis prescribing. It's suggested by applying this theoretical approach will further contribute to reducing this research and practice gap that currently exists. There's many models, theories and frameworks related to behaviour change. There's not one that's been identified as superior to any other. I guess the reason why you would pick any one model or framework over another is after you've read into it and found it to be applicable to you and your research. So for me, the theoretical domains framework I found to be applicable to my topic of surgical prophylaxis. My PhD will be of mixed methods design, quantitative and qualitative, and that will be relying on this theoretical framework. The TDF itself was based on the synthesis of 128 constructs that related to behaviour change, and these were developed from around 30 or so behaviour change and social cognitive theories. These 128 constructs were then categorised into 14 theoretical domains, which I'll explain in future slides. But to explain why I picked the TDF, I like how it adopts a systematic approach to implementation. There's 128 constructs. There's a lot of them. They're within these domains and they all exert their own influence as a barrier or a facilitator to implementation. But they also can build upon one another to exert an even greater influence, and how the TDF allows them to exist independently but also interrelate. I found to be good for me because surgical prophylaxis is not going to be influenced by one facilitator or one barrier. It's going to be multiple factors, and again, some have a heavier weight than others, so the framework really helps me apply that. The framework can also exist as a determinant framework and an evaluation framework. So it can happen at all stages of an implementation stage. So a determinant framework can provide understanding of what influences the implementation's outcome, so identifying these facilitators and barriers at the get-go, or later on as an evaluation framework. So when we look to evaluate the therapeutic guidelines, it already exists, so we'll be looking at facilitators and barriers after its implementation. Going back to what the TDF actually consists of, so there's 14 domains. There's another slide filled with writing as well. So there's knowledge, skills, social, professional role and identity, beliefs about capabilities, optimism, beliefs about consequences, reinforcement, intentions, goals, memory, attention and decision processes, environmental context and resources, social influences, emotion and behavioural regulation. So there's a lot of them, but by identifying these factors we can then manipulate this knowledge into guiding future AMS interventions, policy and practice with the end goal of optimising surgical prophylaxis prescribing, but more importantly patient outcomes. So then leading into my future research with my PhD, the first project is going to be a guideline appraisal of the therapeutic guideline antibiotic surgical prophylaxis. Key Australian stakeholders will be invited to appraise the guidelines, and this group ideally will consist of specialists from surgery, anaesthesia, infection control, infectious diseases and guideline development. And to appraise the guidelines, they'll be given two appraisal instrument tools, the Appraisal of Guidelines Research and Evaluation, also known as the AGREE-2, and the Guideline Implementability Appraisal, also known as GLIA. AGREE looks at the methodological quality of the guideline, whereas GLIA looks at implementability, so how easy it is to implement the guideline into practice. So Kaz mentioned earlier today about how our interventions fit in with the workflow, so that's going to be looked at within GLIA tool. Then following on from this, we're planning a qualitative study that applies the TDF to then further identify barriers and facilitators of surgical prophylaxis prescribing. So that's all I've got within the 4 months that I've been here, but the overall aim at this stage is to develop an increased understanding of the current suboptimal surgical prophylaxis prescribing, and with this understanding we then hope to inform future targeted AMS strategies, so targeted specialised strategies with an underlying theory base to help bridge this gap between evidence and practice, and then with the overall result optimising surgical prophylaxis prescribing. But it's not just about prescribing rates and being guideline concordant. The ultimate goal is improving patient outcomes. And then with that as well, I hopefully would be reducing that burden of antimicrobial resistance as well. Before questions, I'd just like to thank everyone for attending today, and as well thanks to NCAS for giving me this opportunity and present today. So NCAS fund my PhD scholarship, and yeah, I've been very grateful for that, but also to my wonderful supervisors, Kaz, Trisha Peel and Darshini Aiton, who's a qualitative researcher at Monash, who couldn't be here today, and also to the SNAPS team for pulling through and getting some data for me at the very last minute. So yeah, thanks everyone. Questions?
I just wondered if you had any comparison between the data you received from NATS and SNAPS in research prophylaxis and fitness. Is there those same trends this result are?
So, yeah, I do want to
No,
Vicky's collected on specific surgeries, so hip and joint and things like that. So with this, we have a lot of data, we will actually be able to look at that. Fitness is a formalised process to measure surgical site infections, etc., etc. Leon can comment on it. The SNAPS outcome data looks at the specific things we looked at were using demonstrating whether there's a deep-seated or superficial infection. The 30-day was the outcome. Length of stay, readmission, C. diff were the other things that were measured. So yes, it will be really interesting in those specific defined surgeries, like particularly the prosthetic joint surgeries. And perhaps even look at the joint, Trisha's here, and perhaps at the joint registry as well.
Just wanted to comment as well, I think at comprehensive, so the other thing we're doing is actually collecting data on operations where surgical prophylaxis isn't necessarily indicated, and also people coming in for their surgery procedures. So what we're finding is that there are a lot of people who are actually getting antimicrobials when they shouldn't be getting antimicrobials, or patients going home on a few days of antibiotics following fairly minor procedures. So it's I think it complements what's happening in the area of infection surveillance, and it's adding a lot of granularity to the data.
So the VICNES are a core group in the development of this tool, and as Leon was discussing, I think very, very eloquently, it's time that we sort of pull all our various data sources together and make sure that we have a robust picture.
Hi, I was just wondering, I saw the World Health Organization release their global guidelines for prevention of surgical site infections like a week ago, 2 weeks ago, and I saw there were some differences between the therapeutic guidelines and their recommendations. I was just wondering if that's going to influence your appraisal of the therapeutic guidelines and whether that's going to change over time. I'm not sure how people therapeutic guidelines react to, international changes in guidelines, but is that going to be kind of involved in your PhD at all?
Well, with my review, my PhD, I only just started, so by the time I publish it, that's going to be updated plenty more times. So I'll be acknowledging that. And the TG, from memory, their turnaround and review is every 3 years, I'm pretty sure, but then they do respond quite quickly to sort of immediate or urgent sort of changes. So, but I think there's someone from the TG that would probably give you a better answer.
Oh, hi.
Yeah? Sorry.
Now, not only resolving the review guidelines, but thinking about question, we will be revising guidelines every 4 years, so we're actually just getting that time starting next year, so we'll take into account the data that's been published since then.
Glenn.
I was just wondering on that, who I'm correcting is really whether there's any evidence for peer comparison of antimicrobial prophylaxis surgeons. So is there any evidence that surgeons in the same hospital tend to follow the same practice? Or do they just not talk about it to each other and only talk about procedures?
So the SNAPs did take into account the surgeon, but I'll let Trish give you a better answer.
It varies a lot. So particularly in the public, you might have more uniform practice, but certainly a lot of the privately operated individual practitioners, probably like the vets in some way. So also the other thing is, interestingly, with some of the private practices, a lot of very cognizant of the fact that each practitioner is autonomous and that they respect their autonomy, so they've been reluctant to necessarily impose on their practice. So again, that's some interesting observations and things that we'll be teasing out as well.
Anybody else? Thanks very much. So I guess on behalf of Kirsty and myself and Glenn and the NCAS team, thank you very much for staying over the whole day. We've actually had 40 to 50 people who've stayed all day online, which is incredible. Some of whom we know quite well, who are active followers of our work. And I would like to finish up with some specific thank yous, particularly for Rod, who has been tireless in the last few weeks, actually really doing everything. As you know, Phil Russo, who is our centre manager, left to take up his own research position at the Alfred, who will be working in sexual site infections, so we've been left without someone who can do this sort of stuff. So Rob, thank you for a lot of the work and the website work and the pulling together infographics. Thank you particularly to Gemma, who works with us from Guidance, who has been doing a huge amount of administrative support work for all of us, to our NAPS team, who really put the skates on. You know, ACNAPS and SNAPS only just closed, and we're really eager to get the data out to put the infographics up so that we can put them out during antimicrobial awareness week. They're actually already up on the website, so you can download them and use them as you wish. I've invited the paediatric guys to make one, and I've also spoken to Harvey and Yvette to make a sepsis one, so we have a really nice range, and anyone else who thinks of anything else, please let us know. I would actually like to thank our PhD fellows. You know, we've had 2 12-month confirmations, and those who have just joined, they're really working very hard. I think it's a very stimulating environment. You may not be aware of this, but to undertake a PhD at University of Melbourne, you have to actually reach H1 equivalent. It's all very well for doctors to waltz into doing a PhD, but it's actually quite a piece of work, and they've been, every single one has achieved a H1 equivalent, and there's another PhD who hasn't spoken today, Karin Advantage, who has come to us from the Austin, who's going to be working in the immunocompromised area, which is really exciting. And we have very close alliances with Jason Roberts in Queensland, because she's going to be doing some PKPD work. So we are very excited about growing our team and collaborating. The NAPS data, all of that data is available to any of you who wish to undertake any research. We have a research environment and we'll give you the data. We oversee what you'd like to do and support you if you'd like to do a particular topical area. We have had very successful presentations overseas and posters on some of the work directly out of the maps. And people actually really interested in Canada. You know, Kirsty talked about it this morning, but opportunities to do this work overseas. There's been some really great, I'm very, very happy that the important people are here, particularly in the animal stream, to have Darren from Adelaide and Mark down and TG here and NPS. These are the people that we really are the army that are actually helping us to support what we're doing and will continue to do. We are very keen to move forward to planning for next year, and there has definitely been some discussion now with the Queensland and other groups that maybe we need to have a bigger, proper single forum or conference where we can pull everyone together and perhaps do some workshops and things like that. So stay tuned, we'll be making some announcements when we work out what's happening in the next few days. And so I'd like to, I hope I haven't missed out anyone, but I hope you've had a an interesting day with us, and please stay back and have a glass of wine and some trees and continue the chat. Thanks very much.